We know that you're making your way into the room. We're going to make a few announcements. Cheryl has a few announcements before we start, and we're going to go ahead and get rolling. Cheryl?
Okay, good. So good afternoon, everyone. I hope everyone is having a wonderful afternoon. We are so thankful that you have decided to spend this time with the Institute for the Advancement of Women's Health, taking advantage of this opportunity to learn and grow and create community around women's health. My name is Cheryl Thompson, and I am one of the two co-executive directors of IAWH. I want to get a few instructions out of the way so that we can move into our incredible program. Number one, please keep your microphone on mute. If you come off of mute, we will probably put you right back on mute, just to keep the program moving and to cut down on interruptions. Of course, you can open your mic if you are asking a question or you've been called upon. Number two, please use the Q&A button at the bottom of your screen to submit questions during the presentation. We will also address your questions periodically throughout the program when and if they align with the presentation. It may not be possible rather, to get every question related to menopause, symptoms, treatments covered during this 90-minute session, but we will do our best. So please do use that Q&A function at the bottom of your screen. And I think that covers the housekeeping for this afternoon. I am happy to turn the program over to Janine Payne, Co-Executive Director. Janine?
Thank you very much, Cheryl. Okay, before the introduction, I feel it's appropriate that I share a few quotes from people that have experienced reading Dr. Arianna's book, The Menopause Myth, What Your Mother, Doctor, and Friends Haven't Shared About Life After 35. So I'm going to read two, I believe. I can read so many more, but I'll just stop at two. So the first is, reading Dr. Arianna's book, The Menopause Myth, was like having a conversation with a really good friend who cares enough to listen to you and roll up her sleeves to help you. This book will change the game by starting a conversation about women's health that liberates, educates, and gets us really excited about the change. She says, I'm ready. And that's Leslie Fuqua Williams, coach and host of Gather and Shine. And she submitted that, and that is part of, you'll see it in Dr. Arianna's book. All right, but let me tell you, this is another one. There's a woman that reached out to me on LinkedIn. She says, I received Dr. Douglas's book over the weekend and started reading it last night. I'm in just a few pages and already my mindset has been altered. My perspective had been looking at things as downhill post-menopause. Instead, Arianna is showing me the exact opposite and looking at post-menopause as coming into my own. I wish I could join in on the session, but I have a commitment with my in-laws this weekend. It's very personal. She said, I'm very excited about reading more of her book and gaining more insight. All the best. Her name is Vicki Lynch, MHA, and she's the CEO and owner of Next Staff of Northern Virginia. So with that, I am ready to introduce you to, it is just so awesome. I'm just overwhelmed with excitement. So these comments represent how I personally feel about this book, that at IAWH, we call a handbook for anyone who wants to know more about menopause, a person's body, and intersects with health and healthy living. So friends with us today, please allow me to introduce, first through her bio, but then as Cheryl and I and you share a discussion with Dr. Arianna Sholes Douglas. Arianna Sholes Douglas, MD, FACOG, and that's the Fellow of the American Congress of Obstetricians and Gynecologists. Dr. Arianna has dedicated much of her 30-year career to practicing medicine to help women through all stages of life. After focusing the first 20 years of her practice on managing high-risk pregnancies, she retired from obstetrics and for the past 10 years has focused on treating women as they enter the menopause transition. And we thank you. Dr. Sholes Douglas founded Tula Wellness and Aesthetics, a medical practice in Tucson, Arizona, focusing on women's health and regenerative aesthetics. She is the author of the best-selling book, The Menopause Myth, What Your Mother, Doctor, and Friends Haven't Shared About Life After 35. And Dr. Sholes Douglas is double boarded in maternal fetal medicine and obstetrics and gynecology. She specializes in integrative women's health, intimate wellness, and hormone replacement therapy. She incorporates integrative and functional medicine with conventional medical therapies to promote healing. She is a fellow of the American College of Obstetrics and Gynecology and a diplomate of the American Board of OB-GYN and Maternal Fetal Medicine. Dr. Arianna completed her undergraduate degree in biology at Washington University in St. Louis, Missouri, then earned her doctor of medicine at Meharry Medical College in Nashville, Tennessee. She completed her residency and maternal fetal medicine fellowship at UCLA School of Medicine. She later graduated from the Integrative Medicine Fellowship at the University of Arizona, and that's a program founded by Dr. Andrew Well. I know it's pronounced different for some, they say Ville, but we will say Dr. Andre Well. She has appeared on the Discovery Health Channel and served as the woman's doctor on Baltimore's NBC News affiliate. Her writing is published on drwell.com, Fit Pregnancy, Good Housekeeping, and Essence Magazine, and others. In 2016, she was awarded first place in the Outstanding Women's Health category by Inside Tucson Business. In 2020, Dr. Arianna received Southern Arizona's Women of Impact Award and Inside Tucson's Business Woman of Influence Award titled Business Owner of the Year. She also received the 2022 Enterprising Woman of the Year Award. Dr. Arianna, her husband, and their 2 children live in Tucson, Arizona. So we welcome Dr. Arianna Sholes Douglas. How are you today?
I'm great, thank you. I'm really humbled, and I just appreciate your really nice introduction, and it's nice to just hear what I've done over the years. And it sounds really fancy, but it's like, yep, okay. But it's nice. Thank you very much. That was a very nice introduction. But I'm great, and I'm really excited to be here with you guys, and love to do this, love to educate and just empower women and help them to understand what's going on.
Well, that's awesome. And Cheryl and I have a few questions that we want to share, and hopefully it helps to inform others. I know many of you have the book, some of you have the book, and those that don't, I'm hoping that by the end of this session, you're going to say, I have to get this one. This one will be on my list. So Dr. Arianna, my first question is, for whom is the menopause myth written and why?
Great question. So actually, it was really probably written for me, meaning that when I started going through this process, I didn't even realize I was going through it. So it wasn't until years later that I was like, oh, I think I'm going through menopause. And it really struck me because I realized it struck me because I realized that, as a gynecologist, if I didn't understand what was happening, then the average woman just couldn't possibly understand this. And I knew I had been trained in gynecology, and I just knew that no one explained any of this. We didn't learn about this in medical school. We didn't learn about it in residency. And I can't tell you how much it just really struck me that how ignorant I was. And I just knew no one else could understand this. So I wrote it really for the women that were really coming around. And that's why I titled it What You Need to Know After 35, because my symptoms started in my late 30s. And that's why I was just so clueless about it, because in my mind, this wasn't something that was going to even begin to impact me until after 50. And now I'm 20 years in, technically, I'm 57. And I really, again, just felt like this was important for women to know about and to understand. And so it was just kind of written for also the purpose of letting people know you're not alone, because, you know, you're going through so many emotional changes as well. And I just, again, I needed to almost just forgive myself for what I had done. I had quit jobs and cursed out people and done all types of things before I figured out what was happening. So I was just hopeful that maybe someone else could get this information before they made some other rash decisions that might have not served them as well.
Wow, that is it is impactful. And I have to say that you've done that work and that job, because many of us now are more informed than we ever have been about our bodies and what menopause truly is. And I love that you said that it allows you to also like forgive yourself. And I think often, you know, we think we should know everything. I don't care what profession it is. As a matter of fact, I made an admission earlier when I was working through something on Zoom, and I want to know it all, but we don't. And to have a handbook like this is, you know, I just think I'm really grateful for it. And I know other women are as well. So at this point, I will turn it over to Cheryl. I'm going to hand over the mic to Cheryl. I know she has a few questions to ask.
Sure. Thanks, Janine, and thank you, Dr. Arianna. Most of us go to the doctor and we assume that the doctors know everything. And you talked about this just a little bit, just a minute ago. You know, we read that people believe that gynecologists are trained and prepared to discuss menopause and sexual health with patients. This is 2023. What is the reality? What can people expect from their gynecologists?
Well, it's unfortunate, but they can't necessarily expect much. And that is, you know, part of what I want to change. But I think that's, you know, I know that's one of the biggest myths, that people think that the person that is trained to take care of women's health would know more about women's health. But the reality is, they're really, for the average, the average medical school student, I think, gets an hour or two of training in menopause. And in residency, there was literally, I don't remember getting any training in this at all. I remember knowing that, you know, women are going to need estrogen maybe. And at that time, 2002, a study had come out, that the Women's Health Initiative, and that's really what kind of changed the whole landscape for women and their ability to get access to hormone replacement, because the study came out and pretty much said it was bad and caused cancer, and really changed the landscape there. But in any case, there really isn't any information. And if you don't, as a provider, go and get information and study it, or go to conferences, or just really take it upon yourself, then you're just really not going to know. The only education you're going to get is just by seeing patients, and then maybe figuring it out that way, like, oh, okay, everybody's got vaginal dryness. Or but honestly, what I hear from patients, even now, I was with a patient a couple of weeks ago, and she saw a concierge doctor in town in Tucson, and he's, you know, touted as one of the top concierge docs in town. And she had been seeing him for over a year, and he just threw up his hands like, I don't know what's wrong with you. He sent her to cardiologist. He sent her to at least a cardiologist and some other provider. I don't remember. But in any case, it was eventually the cardiologist was like, oh, maybe these palpitations are menopause, but nobody had any idea. And she was like a walking just poster child. And I was just like, this is unconscionable. Like, it's really scary that these are people who, I mean, and if you know anything about concierge medicine, those doctors, you know, people pay no less than $1,500 a year to, you know, thousands of dollars a year to pay more money to get better care. And even those providers don't know. So it just never ceases to amaze me how ignorant. But the good news is that there is work that's happening behind the scenes, and I'm feeling more optimistic because there are organizations and nonprofits that are really committed to changing the narrative and educating providers There is at the Northern American Menopause Society, their website is menopause.org. And if you go to their site, it's a great resource to find providers that have been trained in this topic. So these are the providers that went out of the way to learn about menopause. Because if you just go to your provider, a lot of women say, for example, they're really great at, helping them get through their pregnancies. But after that, those docs, and that's, unfortunately too, where the dollars are in medicine. If you're not doing high volume or procedures, then you can't really make it in the medical profession. So it's not even really set up in a way that allows for providers to sit down and take that time. So that's a long answer, but I don't even remember the question now, but hopefully I answered it.
Yes, you did. And thank you for giving the menopause.org website, because that was going to be one of my next questions. How do you find a doctor that can address these issues? Yeah. So
right now, I think that is one of the best ways. It doesn't mean that your provider doesn't know, but and the other thing I do want to make sure people get is that their provider may know about it, but they also may come in with their own personal bias about it. Mm-hmm. So I've heard people say, oh, my doctor says they don't believe in hormones. And it's like, that's not for them to believe in. Like this is science. This isn't what they feel comfortable about. But a lot of providers, myself included, we were trained under the understanding of that study, but all of the findings of that study, or most of the findings, have really been just debunked and rebutted. But most of the providers that were trained don't know that. So we were all trained thinking estrogen causes cancer and does this and that. But now all the results of that study, they're realizing, oh, it was actually the women over 70 that had never been exposed, but the women who were perimenopausal actually benefited. But nobody went back, and even though they, retracted some of those things that they said about the study, nobody went back to really go back and say, oh, okay, now now we understand that that's not really the case. They're still operating under that 2002 understanding of that study. And so you might have a provider that knows something, but they're still not up to date with hormone replacement. So you really need, that's why I like the NAM site, because that organization really is committed, and they're, evidence-based. Like, this is the kind of the governing body of providers that are offering care for women going through that phase.
Great. So you chose to become an OB-GYN, and you chose to embrace integrative medicine. Could you explain to us what integrative medicine is and how the practice of integrative medicine works on a person's behalf? And also, should women seek physicians that take an integrative approach to medicine?
Yeah, so integrative medicine really just takes it's a combination of conventional medicine. It's not like woo-woo or things that aren't conventionally based, but it provides evidence-based medicine to support alternative health. And we call it alternative, but it's really not alternative. It's looking at your diet, looking at your, mental state, your movement, like really all the things that you really kind of don't get when you go to the doctor. Like, most doctors aren't trained in nutrition. They're not trained in just mind, body, spirit. So it really does incorporate mind, body, spirit, all of that. It incorporates other forms of medicine. So Ayurvedic medicine, traditional Chinese medicine. And so conventional American medicine is actually the newest medicine out there. So as Americans, we, think we kind of know most of the things and we're in front of the curve, but there's medicine from, eons ago that still informs us now. And so it incorporates both of those worlds, but it is evidence-based, right? So there's other alternative medicine, but they're not necessarily evidence-based. So it's integrative medicine, or another word is functional medicine. They're not exactly the same thing, but they kind of fall under, I guess functional medicine would fall under integrative medicine, and functional medicine is really probably a better and more specific term that I would use in my practice, because functional medicine looks at the root cause of disease first. So for example, if you have a stomach ache, if you go to a conventional doctor, they're probably gonna, they'll ask a few questions more than likely, but they'll probably give you a pill to stop your pain from your stomach, or give you a pill to make your gut work differently. Whereas a functional medicine doctor is going to really test your gut, figure out, is there overgrowth of bacteria? Is there a leaky gut syndrome? Like, they're going to really delve into what is the reason why your gut is doing this, and then they're going to address it through your diet, through supplements, and so again, most conventional docs, we weren't trained in any of that. So it really is a whole nother like subspecialty of medicine. And what was the second part of the question? Like, what is it? And then how do you, I can't remember the second.
Should women seek physicians that take an integrative approach?
Yeah, I think
functional
so.
approach to medicine?
I think if you're interested in really looking at the root cause and really looking at your health holistically, I absolutely think so. And you would not just look up integrative, but I would look up functional medicine. And a good resource there is the Institute of Functional Medicine. And they have doctors that are certified. Now, you don't have to be, I'm not certified in functional medicine. Like, it takes years to get certified, and it really is like a whole nother specialty, but it is complements conventional medicine very well. But you'll see results, I think, more quickly and deal with your issue more so when you reach or when you are dealing with a doctor that has that type of understanding. So yes, I would recommend it.
Great. Okay. At this time, it would be good to continue dispelling myths, and we're going to do that. But we want to show a very short video created by the National Institute on Aging at the National Institutes of Health. This short video covers the foundational basics of what menopause is, when the transition begins, how long it can last, and when post-menopause starts. So let's take a look at this video.
Larissa is 52 and is starting to notice changes with her body. She wonders, is this menopause? What is menopause? Menopause is a normal part of aging for women. Specifically, it is a point in time 12 months after a woman's last period. The years leading up to that point are called the menopausal transition, or perimenopause. The menopausal transition typically begins between ages 45 and 55 and lasts about 7 years, but can be as long as 14 years. How long it lasts can be influenced by lifestyle factors such as smoking, the age the menopausal transition begins, and race and ethnicity. During the menopausal transition, estrogen and progesterone levels, two hormones made by the ovaries, vary greatly. Women may experience unpredictable hot flashes, sleep problems, changes in monthly cycles, and other symptoms. A woman has reached menopause when she hasn't had a period for a full year, after which she enters post-menopause. Not everyone's experience is the same, but remember, menopause is a normal part of aging and not a disease that must be treated. If you have questions about the menopausal transition, talk with a doctor. Learn more at www.nia.nih.gov/menopause.
Great. So
I just have to take one issue with that video. I love the video. The only issue I have with it is that she was 52 and they should have had her at 42 because the average woman, they're not going to just start. The average age of menopause is 52. So what that means is that is the age where a woman has already had cessation of her menses for 12 months. So that would be, she stopped menstruating at 51. So then by 52, she's menopausal, but you can have perimenopause, which I'm sure you're going to ask me about, but I'm just jumping ahead. But that perimenopause can be 8 plus 10 years before that. So if she started having symptoms or she was menopausal or stopped her cycle at 51, she could have easily started having perimenopausal symptoms at 41. So, but I know we're going to get into that, but I just need to throw that in there.
Right, yeah, we need to do the math.
Yes.
Okay.
There's serious math. That's the problem, is that people think, oh, 52, they're thinking it's going to happen at 52, but it's not. And so and a really important point I want to get across is that it's not the menopause, it's the perimenopause. That's the problem, right? Because by the time you're menopausal, you've already gone through all that. You've gone through it, right? And so you may continue to go through it in your postmenopausal, but it's what's happening before you even get there. That's the issue. And that is an issue that unfortunately coincides with oftentimes the peak of a woman's career. Times, you know, for some women when their children are going through puberty at the same time. And so there's all these other factors that are happening. And again, they're just not aware of it. And so they're trying to manage all of these things and not recognizing, they're thinking, oh, in 10 years, that's going to be an issue, but you could be in the throes of it, you know, early 40s very easily.
Yeah, you're addressing all of the things that I was about to ask you, the whole menses to menopause journey. And it looks like the slide that's up is beginning to talk about that. So could you continue, educate us more about that?
So, you know, one of the most common things I see with women is irritability in the early stages, worsening PMS, this irritability, like I hate my husband, I just hate, people irritate me, I'm snappy, I just don't have tolerance. Their anxiety, depression. If you had a history of anxiety and depression in the past, it's like it tends to come back or worsen. But some women have no history of it and just all of a sudden have more anxiety. A lot of women report feeling like they have ADHD, like they just can't focus, they can't remember anything. My personal experience literally was that I was, I think I wrote about in the book that I was doing surgery, and I'd done C-sections, like thousands of them. And I could literally do them in my sleep, because I joke, like half the time we were half sleeping when we did them in the middle of the night. But this particular time, I just remember having this brain fog. It wasn't even a fog, it was a freeze, because I just could not remember what the next step in the surgery was. And so I was with a resident, and again, they're training and, you know, they want to do everything anyway. So I was just thankfully with a good resident that really, but they had no idea what was going on. And I just literally was like, I had no idea what the next step of this case was. And I thought I was getting Alzheimer's. Like I didn't want to talk to anybody, because I was like, oh my God, like, I don't want to lose my medical license. Like, I don't even know what to do with this, because it's just, this is going to be a problem. But those symptoms, you know, hit people, and they're all listed here: the memory, the attention span, the pain with intercourse that happens really mostly because of vaginal dryness, urinary incontinence, the frequency, your skin itchy, palpitations, shortness of breath, the hair loss, that's a big one. And of course, aesthetic wise, our faces, our bodies are changing. To get the little belly fat that don't seem to go anywhere no matter what you do. And you know, there's all these other lovely symptoms. I'm actually about to get me some Invisaligns, because your teeth literally loosen. And it's like my dentist showed me my x-rays from my teeth, like, I don't know, even 5 years ago and now. And it's like they went from like this to this. And I'm like getting food all in my mouth. Like, what is this? Like, these are all little things that you're just like, okay, wasn't planning on that one. I'm like, what is happening in my mouth? But another symptom that's actually really common that women don't, I mean, we associate hot flashes, you notice hot flashes aren't even on here. Well, they're on the other graphic, but another symptom, joint pain, is a big symptom, and that's just been recently documented as one of the more common symptoms. And now frozen shoulder, I'm hearing that one a lot. That one's a new one for me, but there are just all types of things, and you just don't know. You start having, they're just kind of weird symptoms that you can't really associate with anything, and so I think they just get thrown in the bucket.
Me?
Oh yeah, and I tell you, yeah, I think they get thrown in a bucket, but and often, as you mentioned earlier, you know, our health professionals, you know, yeah, many of them do a great job, but unfortunately, sometimes they're not following the breadcrumbs or helping us follow the breadcrumbs, you know. So,
Yes.
which is why, I mean, having these types of conversations is just really helpful, because we realize a lot of the work we have to do ourselves, you
You
know.
do.
And
Yeah.
yeah, please.
Yeah, no, I would say, and that's not a terrible thing, that we have to do that work, because I do think, unfortunately, a lot of people, they just rely on providers they just want to go and be taken care of. And that's just really not a good way to approach your health,
Mhm.
because, seeing of your provider is like having a relationship. It is a relationship. That person isn't really there to make the choices for you. It's kind of like a parenting an adult child. You're an advisor at this point. You're supposed to figure this out. Obviously, there's some things that you can't, but you need to really start to pay attention to your body, understand, oh, this is what's happening, that's what's happening. But so many times, patients, even the ones that I see, I try to train them to be like, listen, every time we go over labs, I'm going to give you your labs. And I need you to you need to understand what these numbers mean. Like, I understand them, but you need to understand, like, what's your hemoglobin A1C, what's your cholesterol, like, know your numbers. I think there's even a commercial around that. You need to know that. And you can't expect your provider just to be able to figure all of this out for you. That's just an unrealistic expectation. And on top of that, I will say that when somebody comes in, think about it in any other profession. If somebody walks in your office and they're like, oh yeah, I don't know. I don't know why. If you're seeing a lawyer, well, I'm not really sure that this or that. And it's like, it's hard for people to help you when you can't give them any information. So when you come to me and you're just like, yeah, I think I had a mammogram. I don't know, I had some labs and somebody said that something was wrong with my liver. And I'm like, okay, but what? Like, don't you know? Write it down. Like, you might not understand it all, but write it down. Make notes when you go to the doctor. Get your labs. Like, be informed, because the opposite of that is if a patient comes in the office and she's got papers and she's got studies, I'm like, oh, let me get right here. I need to know what she's okay. I need to be on top of my game. I mean, that's just life, right? You're just people that show up expecting more and who are educated, they show up, you're going to pay more attention to them, because you have to pay more attention. The other people, if you're having one of those days, you're like, well, she don't care. Well, I care, but I can only care so much. If you don't care, how much am I supposed to do this, right?
That's hard. That has to be a challenging, and I know people expect, and I'll say people in my generation, and some people know how old I am, but in my generation, you were somewhat taught that the doctor knows it all,
Yeah.
and you present yourself that way. Although my mom was also a nurse, and my sister's in the audience, and she will tell you that there are things that we just knew to, and it's not even aggressive challenging, but just pushing back and going, wait, I didn't quite get that, or I didn't understand that, and taking your own notes. And that's what I hear you saying, just knowing, and I know in your book, you have a health tracker as well, that, and it's very helpful to go through and start jotting down what experiences you're having in your own body, your own self, and keeping track. You mentioned like your mammograms and so forth. So this discussion, yes, it's about menopause, but I love how it's just embracing, it's holistic. I mean, it's a whole, it's taking our whole selves and discussing how we're supposed to be caring for ourselves so that we can help our physicians care for us. You know, it's but I have a question. We were just talking about, and I see this slide here, and I'm going to pull this up. Give me 1 second. So you write the following. You say one of the biggest perimenopausal complaints is decreased libido, right? Given the fact that we can be in our reproductive years, you were just talking about that, you know, careers and everything else going on in our lives. But given the fact that we can be in our reproductive years and perimenopausal at the same time, what,
Yes.
right? What should women know about libido? And let's be clear, I pose this question on behalf of anyone. It's not just solely focused on people who want to have children necessarily, but what else should we know, you know, about libido? What else can we do? I have a follow-up question as well.
So do you mean like libido or fertility?
You know what? I'm going to say, can we talk about both? But the reason why I focused on libido is that so that anyone in the audience who may necessarily not be looking, you know, to have children necessarily, I didn't want us to just move in one direction. So please, as doctor, you know, just help us out here.
Yeah. So obviously you don't have to have a libido to have kids.
That's right. Just
So that, but you know, it can be a tricky time because your hormones are fluctuating so much, and so it's sometimes difficult to know your fertility, meaning your risk for being able to get pregnant. And so there's a lot of variables that are happening there, but oftentimes it's not that libido always goes down. For some women, libido goes up. I think it goes up less frequently than it goes down. I hear it go down probably 90% of the time, and maybe it goes up at best 10% in my patient population. So women, and a lot of women, it's like they could definitely be with partners that they care about and love. And so whenever I have that conversation around libido, my first question is like, do you like your partner? Because, you know, for women, I say it starts here, then it goes here, pointing to my heart, and then it's down there. And then for men, if you are heterosexual, then your partner might, you know, it may start there, and then it goes here, and then it might go, maybe it'll go here. We don't know where it goes sometimes. But depending again on your orientation or what have you, you know, you will have sometimes those disconnects with your partner. So a lot of the women I see, they feel badly because they want to be intimate with their partner, but they just literally just don't feel like it. Like I just don't feel anything. So this could definitely be hormonally related, but it's also stress plays a big part in it. I see decreased libido, especially in younger women as early as their late 30s, because they have small children, they're tired, they're working, and it's like, it's hard to have a libido when you're exhausted. Your libido really requires what's called your parasympathetic nervous system, but we tend to operate in our sympathetic nervous system. So we are typically running, going, fight or flight. We're just going. And so it really requires us to turn off our sympathetic nervous system and turn on our parasympathetic, but that could take, you know, a long time. And if you got kids that you just put to bed and you just went to clean the kitchen and then you're trying to get ready for work the next day, like you're already trying to process today and what's going to happen tomorrow, it's really hard to get there because you really, for most women, the average woman isn't driven that way. I would say the average woman that I see, and I dare say, I mean, I see hundreds of patients, so I don't think I'm that far off, but I'm not saying in any way that women don't have libido during this time, but it definitely fluctuates. And in terms of the potential for getting pregnant, There are some labs, there are some things that we can look at. We look at one hormone in particular called your FSH. And if that is a certain number, then it's like, yeah, you're not going to have a baby. And so you could still have a high FSH and still be menstruating. But if it's at a certain point, it's not going back down. And that's really what informs that. But you still have to be careful with appropriate birth control. Again, in certain situations, if your partner, it doesn't either have a vasectomy, or if you're not in a heterosexual relationship, then some things you don't have to worry about, obviously. But for those of you that do, you definitely need to pay attention, because that's when you get the twins. That's when, you know, your fertility actually almost peaks a little bit, and then it just goes away. But yeah.
Thank you. Thank you. Thank you for that, and helping us, you know, sort of move through that. And you're absolutely right, you know, about libido. You don't necessarily have that, you know, it can have nothing to do with your fertility. And I think I was thinking, I thought more about just having the desire, you know, and, you know, to have sex, and how that ties in with perhaps fertility, you know, your not necessarily with your ability to have children, but wanting to have sex. And it's just, you know, it seems like it's tied, you know, in some way.
Well, yeah, it can. I mean, typically during your menstrual cycle, if you're still ovulating, then there's a little peak in your testosterone level right around the time of ovulation. But that's actually why some women have such weird, or not weird, but some of the symptoms that they're having have to do more so with the fact that you're not ovulating. So in the earlier part of your perimenopause, your estrogen levels actually are fine. That's why a lot of women in early perimenopause, they don't have hot flashes, because they still generally have enough estrogen. That's not so much the issue. What's happening is they're not ovulating anymore. So what happens is, during a regular menstrual cycle, your estrogen levels are going to go up, and then you're going to ovulate, and then your progesterone levels are going to peak. Yeah. Well, your progesterone is what counterbalances your estrogen that peaked at the beginning of the cycle. So once you ovulate, exactly 14 days after ovulation is when you're going to bleed. But what happens is you stop ovulating, and so you just keep making estrogen. You don't make any more progesterone. And so that's why your cycles are all off, because you're really not ovulating. You're not making this progesterone. You're not balancing out your estrogen. So you bleed erratic. That's why you're having heavy menstrual cycles. That's why your bleeding is erratic, because you're not ovulating anymore. It's called anovulatory bleeding. So that's why a lot of women will get endometrial ablations during this time. They'll get hysterectomies, I would say, you know, before, and Black women in particular are more prone to be offered that as a procedure. So you just need to be aware that some of these things you're seeing are really hormonal changes. They're not structural changes. We also are more likely to have fibroids. So, you know, there's definitely that part of it. But I've seen plenty of women that it's like they had a hysterectomy, and it's really just because they had anovulatory bleeding, and their doctor just never took the time to really help balance out their hormones and see if that was really something that could benefit them. Yes. I'm not saying that they didn't need those in any case, but you just need to be aware that there are different reasons. But that cycle affects everything. And that's, again, why women they have more irritability. That's why natural progesterone is just like a lifesaver for a lot of patients. That's the most common hormone that I'm going to talk to them about, especially in the early perimenopausal phase. So yeah, this graph here at the beginning of it, oh no, this is over your lifetime. So this isn't a menstrual cycle, but it's good enough, because this is, I like this just to explain why you have some of those symptoms. And this is what I share. This is what's happening for a lot of women, especially if they're in their 50s, they got teenagers. They're teenagers, their hormones are right there at puberty. The purple line is showing your estradiol, that's your estrogen level. So really the only thing you really need to look at this graph is the purple line. where you see at puberty, your hormones are basically doing all of that. And then during your reproductive years, they kind of stable out. And then during perimenopause, they start doing all that again. So I joke and say, but now you have a job and you got kids and you just can't be crazy, but you feel just like you felt, you know, over here. But now you just weren't ready for this on this side, but that's really what's happening. And I don't think I gave you a slide of just the menstrual cycle, but this doesn't really quite explain it. But at the end of the day, this is when you're gonna really see those changes, especially in that perimenopausal period. And then in the postmenopause, you know, things settle down, but you can still, you know, you're still gonna have hot flashes. You still can have night sweats. You're still gonna, all of this stuff still goes on. I'm postmenopausal, I don't know, at least 10 years now. And I still have night sweats. I'm still irritable.
So do I. I think it's amazing. I know they say in postmenopause, you know, you could be going through symptoms for another 10 years or so, you know, and this is actually a pretty good segue into discussing myths that women and doctors often hold about complex issues of sex hormones, you know, and I'm wondering if you could share of how much of the menopause myth covers about, you know, the symptoms of estrogen, progesterone, and testosterone, and what are the takeaways for people to consider when they're addressing, you know, the estrogen levels and so forth with their doctors? And I think there was another slide that might speak to this a little bit more. That I think is the fluctuations in hormones, and you may have. That
slide was just trying to give you an idea of why you were feeling a little bit crazy, because during any 24-hour period, your hormones are just going. And that's why sometimes doing lab work, oftentimes people, I hear this all the time, oh, I went to my doctor, they said my labs are fine. That means nothing. It has nothing, your labs have nothing to do with perimenopause. So that's just, I'm not saying it shouldn't be done, but at the end of the day, it's just, don't even bother. They're not inform you definitively as to what.
Excuse me one moment. It sounds like, excuse me, someone has their microphone open. I can't tell just from this perspective who it is, but if you wouldn't mind, if we could just be attentive to our mics. Thank you.
So yeah, this just shows the night sweats, hot flashes, mood swings. It doesn't really, I mean, this doesn't really tell you a whole bunch. It's just basically letting you know your hormones are fluctuating. They're all over the place. And so that's why if you go to your doctor, your estrogen level may look one way today. It could look totally different next week. So we can't really use that as a guide. And, you know, if your doctor says, oh, everything is fine, it's diagnosed by symptoms, right? So if you have irritability, if you're having difficulty with sleep, classic sleep issue is you fall asleep okay, and you wake up at 2, 3 in the morning, and then you cannot go back to sleep. You just, and then that's usually worsened by, you know, you're thinking about work, you're thinking about all these things. And so when you compound just our monkey mind with the hormones, it's just a bad combination. And so people aren't getting sleep. And then that sleep deprivation is affecting them the next day, which is causing fatigue. And that just enhances the emotional ability. You may have the irritability, like sex drive, like all of that is affected because the quality of your sleep is impacted. So getting a good night's sleep is really imperative. And so I'm just a really big fan of natural progesterone, because that's definitely a hormone that we make, which is not the same as the progesterone that you get in your birth control pills. Because birth control pills those are all synthetic estrogen, and those are progestins. Those are not natural hormones. So you just have to be, you know, thoughtful about when you're a provider, because your provider may say, oh, I'm going to give you some progestin, or they're going to give you medroxyprogesterone. That's something that's similar to what would be in your birth control pill, but that is not going to help you with your sleep. It's going to help you with your bleeding, but it's not going to help you with your sleep. So natural progesterone. And if your doctor doesn't know about natural progesterone, then they probably, I'm going to
That
go
was
out on
my-
and say you probably need to. And again, and it's not, I think I saw something in the chat, it's not your doctor. It can be your nurse practitioner. In fact, I rather prefer patients during this period. I think nurse practitioners could be superior because they tend to be able to take more time with you. And I used to see a nurse practitioner before she retired. I just think there are some wonderful ones. And even in the NAMS, the resource that I quoted, those are,
Yes.
they're going to be nurse practitioners in there as well. So when I try to say provider, because I really do respect that there's doctors, but at the end of the day, I mean, I'm probably more partial to somebody seeing a nurse practitioner who can take that time and really be with you, as opposed to a doctor. And I'm not saying that you can't have a good relationship with a doctor, but just don't discount that at all, because that could be a excellent relationship. And even if you still had a gynecologist, it's still a great relationship to have, because you really need somebody during this time who has the time to sit and talk to you, because this is really, again, I mentioned it before, medicine doesn't really honor education and time with the patient. You are rewarded by procedures or volume. And if you aren't doing one of those, then you literally can't make money in medicine. You can't make money by sitting down and spending 45 minutes with a patient to talk about menopause. And that's, unfortunately in my practice, I've had to switch from not being, I can't take insurance anymore because I can't afford, I want to provide that service. And I did that for almost 10 years, but you just can't do it.
And I hear you saying, thank you for that. I think many of us are nodding our heads and in agreement. And when you speak about nurse practitioners, I know I have one. I was my husband was in the military for 20 plus years. And my clinician was an MP. And I was so fortunate. And when because of the time that the MP will take, the courtesies that they often take with you, and not to say that doctors don't, but generally speaking, my MPs were off the chain and still are. I still have another an MP where I get my GYN care, and I absolutely love her. So I'm glad who I'm not sure who that was that dropped that into the chat, but you're absolutely right. And if you can't find joy in some other areas or other clinicians, perhaps start looking at your MPs. Do not forget that.
100. Yeah, I would even say start there.
Yeah. Okay.
Because no, I mean, like I said, I think I've worked with nurse practitioners and midwives, in particular, midwives when I was doing high risk OB. And I love that, because then, they took care of the patients, they spent that time, they gave them everything they needed. And then when they had issues, I would, take care of that part. But I just knew that the patients really, they got so much more seeing the midwife than they did seeing a doctor, wow. Especially while you're pregnant. I would 1000% consider that.
Amazing. Thank you. I'm going to.
I wanted to jump in and say thanks to Sue, who did put that comment in the chat, because that's been my experience as well, having a nurse practitioner, having someone to go to. And when Janine, you were talking about connecting or, looking at and collecting the breadcrumbs and connecting the dots, it's beginning to sound like, particularly around this topic, that there probably the team approach, getting information, because it seems like not one particular profession has all the answers. And so just, feeling like you're coming to the clinician with a lot of anecdotal type of symptoms and things happening to you. It seems like it needs to be a team to help pull all that together to make it all add up and make sense.
Like a medical home. Yeah. Cheryl, actually, the mic is turned over to you right now.
Oh, sure. Okay, I can ask the next question. We're starting to hear more about heart disease, cancer, and their relationship to estrogen. And you mentioned one myth in your book that's often discussed, taking estrogen during perimenopause, early menopause. will increase the risk of breast cancer. What is the reality?
That is not the reality. So, you know, it can be a controversial topic because it's been so ingrained in our head, like people really believe it's a fact. But the fact is that, you know, even in the study that they touted as, oh, this is the reason why we're going to take everybody off of estrogen, even when you go back and look at that data, if you stratify that data for perimenopausal women, literally the women who took estrogen alone, not estrogen with progestin. And also remember that the estrogen that they were taking was a synthetic estrogen. And I'm not saying that there's a significant difference per se in terms of cancer risk. We don't really know in terms of estradiol, meaning our more bioidentical estrogen versus a non-bioidentical. And all bioidentical means is that it has the same kind of chemical structure as the hormones that we make as a human. So the estrogen, for example, in Premarin, which was the type of medication that was used, that came from the urine of pregnant horse mares. So that's the chemical. It's similar to human, but it's not. So anytime you're going to, first of all, take estrogen, I recommend you take what is considered bioidentical. Bioidentical doesn't mean you have to go to a compounding pharmacy or go do something woo-woo. It's literally like an estrogen patch. That is estradiol. You want to take the hormone that has the same chemical structure as, you know, you have as a human, right? But the myth, or I guess the going idea is that, you know, estrogen causes cancer, but in that group of women, it actually had a decreased risk of breast cancer. It was decreased risk of colon cancer. There still is evidence that estrogen decreases the risk of colorectal cancer, decreases the risk of Alzheimer's. And we know that your risk for heart disease goes up. If you just look at the graph of when women get heart disease and bone loss, it correlates exactly with our estrogen levels. So estrogen is actually cardioprotective. It's not cardioprotective in a 70-year-old woman who has never been exposed to estrogen. That's not when you would start it. But when you start something like this in the perimenopausal period, then there definitely are some things that will be protective. And so I know in a lot of communities, estrogen, again, there's just a lot of fear around it. There's just a lot of misunderstanding. And I understand why. I mean, I felt that way. That's how I was trained. That's why if you go to a provider, they're going to say, oh no, you know, they could say that if they haven't been informed. And again, a lot of people just haven't gone back and looked at, okay, the study that really informed us to practice this way has been really debunked now. We don't think of it. So we're still working on how to re-educate providers to understand that. There's another resource, the Society for Women's Health Research. They have a really nice little pamphlet. It's called the Menopause Toolkit. And I actually helped work on creating this toolkit. It's for providers and for patients. But at the end of the day, this is a nonprofit organization, and they have a panel of professionals on there that are Harvard emeritus, researchers from all over the country. Like, again, I was invited to be on this panel, and I felt a lot of imposter syndrome there, because these people I felt like really knew and researched this. And they're the ones that were saying, we need to educate doctors and patients on how estrogen really works. So it really wasn't until about a year and a half ago that I felt 100% confident saying that statement. I had been hearing it at my functional medicine conferences, in my integrative medicine conferences, but I was still like, you know, I'm not fringe. Like, I really am still a conventional medical doctor. That's how I've been trained. And I don't want to do anything to mislead people or, you know, just be fringe or out there. But there really is a movement now that's in the process of trying to re-educate providers in particular so that they can educate patients. So the long answer to that is estrogen is safe. There are definitely some people that it's not best. The safest way to get your estrogen is transdermally, so estrogen patch. If you go anywhere and somebody tells you you need to have a pellet, and they don't talk to you about any other type of ways to get your estrogen, I would go the other way. Pellets are not terrible, but they're not for everybody. And that's definitely not where I would start with your understanding of hormone replacement. And let me explain. A pellet is a little pill that we make a little incision in the skin, and then we take like a little trocar like this, and we create a little hole, so to speak, and we put the pellet in. It actually goes in your backside. We put the pellet in, and then it lasts for about 3 months. It's a great way sometimes to get testosterone, but it's kind of controversial. It's not widely accepted by the American College of OB-GYNs or even the Northern American Menopause Society, but transdermal estrogen patch is the simplest and easiest way you can get your estrogen. Orally, estrogen has to go through the liver, so we call that the first pass effect, and it can have other impacts on your clotting factors, so you could have increased risk for blood clots. And so you want to get your estrogen as safely as you can, and that would typically be a transdermally. But if you have to take it orally, the risk isn't, I wouldn't say it's hugely significant, but if you have a history of blood clots and things, your doctor's probably not going to put you on estrogen anyway. And it's a hard area to navigate. If you have a family history of breast cancer, it is still safe, because just because somebody in your family had it doesn't mean that you're going to have breast cancer. You really need to assess what your actual breast cancer risk is. And then that's a personal decision. I have a lot of patients, their mom had breast cancer, their grandmother, and they don't want to. If you have a personal history of breast cancer, the average provider is not going to put you on estrogen, although that's in some circles, that's controversial as well. So I know I probably didn't answer the question because it gets controversial, but overall.
You've reached it. You've talked about it. It's just that women have to go through so much. Just listening to this conversation, there's so much to consider.
It is a lot, especially on that topic. I feel bad. I feel bad for lay people because I barely feel comfortable and understand it. If I'm honest, I'm like, okay, are we okay? I mean, because I'm telling other people, so I want to make sure I'm giving you, good information. So all I can tell you is my kind of aha moment, my moment where I felt like, okay, what I've been doing for the last 8 years is okay. But, I was a little sometimes like, I'm not sure. Mm-hmm. And that's just the sad. I mean, the research in women's health is just, we're so behind. Yeah. And it's just, it's just starting to scratch the surface. The NIH just created a category for menopause, I think a couple of years ago. It's ridiculous. Yeah. It's really ridiculous. There's a book called The Sweetness of Venus, A History of the Clitoris.
Nadine had to send me the link.
Sarah Chadwick.
Can you say that again? The sweetness of what?
It's called The Sweetness of Venus, A History of the Clitoris.
Okay.
And she really talks about, it's not so much about menopause, and I haven't even finished the whole book. I read probably almost half of it, but it really does help you understand how in medicine, some things they just literally made up about women, especially about our genitalia and understanding our sexual response. It goes back as far as Hippocrates. They literally just made up stuff and then up until I think the clitoris was just imaged for the first time through MRI in 2002. It's crazy if you hear how behind we are. It's literally in the 2000s that certain things are just being discovered. Medical school anatomy books, didn't even have the clitoris in them. Like they're just starting to show real female anatomy in the books, and they don't even have the clitoris, like the full mapping of it. It's mind blowing. But if you read that book, you'll really begin to understand how we've been really just been given we've really almost been fed a lie about a lot of things. And there wasn't this understanding. We were told and taught things that you kind of took as fact, but you didn't, but you're like, well, where did that come from? And then you go back and you realize that came back from, 2000 AD, and they literally made that up. So it wasn't even based on anything. It's impressive.
So I know women who are taking all kinds of supplements for everything. So can you talk to us, you talk about this in your book, about hormone balancing supplements and botanicals and other treatments, and what's the best way to begin to have this kind of discussion with your doctor, nurse practitioner, midwife, et cetera?
Yeah, well, I'm going to tell you that you really, in my opinion, one of the better people to talk to about any type of supplements around menopause is probably not going to be a provider. Maybe a nurse practitioner if they're really informed, and maybe a few doctors, but even doctors who are informed in menopause are generally not informed in the supplement area. So a naturopath, a really good naturopath. And I know it sounds crazy. We got to go to the naturopath. We got to go to the nurse practitioner. We got to go do our research. We got to do all these things. But unfortunately, if you want to get the best information, I think naturopaths in that area are superior to anybody because they really understand. Or functional medicine doctors. Like that's why I like functional medicine docs and integrative medical docs, because they understand the use of supplements. And I didn't mention that when I was talking about the difference between them, but that's where we will incorporate traditional Chinese medicine. So like, for example, acupuncture can be wonderful way and really almost first line for really dealing with some of the symptoms. And the supplements, I mean, that is such a tricky terrain. But at the end of the day, one of the most common supplements I recommend for women, especially in the perimenopausal period, is chaste tree or Vitex, because it helps to balance out your progesterone. And I mentioned that earlier, like that's the bigger issue for women in the early part of perimenopause is they're not ovulating. So that irritability, that worsening PMS, even the menstrual cycles, chaste tree or Vitex can be really great for that. And then there are a lot of supplements that are great for menopause. Some of them aren't as good as others, but it could be a combination of things like magnesium, obviously black cohosh. I'm having a total brain freeze now on the supplements. So
let me just add a follow-up question, because can you offer any words of advice or caution? Because people are always pushing supplements on Instagram, online. How can people be careful about what they're doing? I know you said the naturopath. Any words?
Yeah, I would say, I think a naturopath, like, honestly, I'm not knocking, I don't know who, I know that there are probably some great supplements and I'm not knocking them because I just don't know which ones you're specifically talking about. So I'm sure there's some great companies that are doing great work, but I just think you just got to be careful. And honestly, what I see happening is that people are all getting on the menopause train now. Like everybody, it's becoming more popular. It's becoming more just in vogue, and they're just creating all these products for women. Yeah. And I'm a little skeptical. Like there's definitely money involved, and so you need to really vet who you're listening to and look at credentials. At the end of the day, who are those credentials? Like you could even get as specific as where are they sourcing their supplements from. But I think the average person, it's hard. I don't think that's the first place I would go. I would just take the time, pay a naturopath, and, you know, because the amount of money that's like a multi-billion-dollar industry, and women are just buying stuff and trying things. They're just trying to self-medicate. And it's just really, that's just a hard area to navigate. So I don't really know how to tell you what to do there outside of go to a professional who's going to use medical grade supplements. There is a site, it's called Full Script, and that's where I prescribe my supplements for patients, and most of those are medical grade supplements. So companies like Orthomolecular, Thorne, Zymogen, Pure Encapsulations, those are, you know, just your standard medical grade supplements. Again, I'm not knocking the other ones. I had some patients, they come in with stuff and I'm just like, I've never seen this, I've never heard of it, but she's like, well, it's working. I'm like, okay, well, I guess you're okay. But it's unfortunately, those are waters that you have to just figure out, but have the help of somebody who really has your interest first.
Can anyone order, I mean, just the average Janine order from Full Script, or is it through their clinician? You know,
you have to order through a clinician, but I think if you go, like, for example, I have a Full Script site. You don't have to be my patient, but if you just go to the site, but you have to have a link, I think, to that doctor's site. But I would say you could try to go on Full Scripts. I don't know.
I'm going to drop it in the chat just for people. It's just for information, for you to be informed. And because
I have like I said, it's just knowing that there's a good resource for some supplements there. I don't know from the patient experience what has to happen, but if you can find my link, then I know, because I even have some protocols on there, so I can share a protocol with a patient. So it's like, these are the supplements that I like for, you know, menopausal symptoms. And so different providers will have that. Okay. But I'm not sure if you could just go on there and not have a provider, because I don't know how that works if you don't have a specific one. That's just where I typically send patients.
I'll try to put yours. I'll try to. So is it on your website? Is it some?
It's on my Instagram page on that link tree. Okay. That's how you get to my Full Scripts.
Okay.
So,
and we are dropping in the chat, or have been, or will, how to reach you, to include Instagram. So if you all go to her Instagram page, you'll be able to go from there. I think that's the easiest way. Yeah, that's awesome. It just seems so it seems complicated, but at the same time, what I love about this discussion is that it really puts a lot of the responsibility, yes, on us to know, to ask the right questions. You know, again, the breadcrumbs, I think that's just an issue. But a lot of what we're asking about, or I'm having, you know, I'll just say migraines, you know, am I going through menopause, you know, prompting our clinicians based on what we know about the changes in our bodies. That's what I hear. I hear a lot of that empowerment language coming from you.
Yeah, I think you can definitely feel more empowered, but in your early stages, it can be very overwhelming and you can feel really just confused. But I love that analogy of breadcrumbs, because it is breadcrumbs, because you start out with one thing and then you're like, oh, you got this other thing over here. And you just hard to tell like how to connect all the dots.
Yes.
So that's why journaling, and I think at the end of the day, what this period does is it really forces you to take the time to pay attention, because, you know, we've just been able to, up until this point, just kind of go and do it and make it happen for the most part, unless you had some significant, you know, other medical issues. But now it's like, okay, I really need to pay attention. And you can't even help yourself or find help until you really know what's happening, which means you got to start tracking things and paying attention. What did I eat this day? And how much did I sleep? And, and what really, and those are significant components of it too. Just your food alone is a huge, can be a huge impact.
We have several questions about really what we're eating, but Cheryl, you may have had another question. Did you have another or?
Well, yeah, it just kind of ties in with what you're talking about right now. You talk about being an unsilenced woman and asking those questions, and because your health is at stake. And so you speak of your personal journey in this space. Can you talk about the key takeaways about the thyroid and adrenals?
Yeah, so thyroid is like it's literally a whole nother conversation. And literally, so I'll give it a minute here or two, but at the end of the day, your thyroid is a gland. It's located, here in your neck, and it's responsible for basically your metabolism at the end of the day. But as we age, our thyroid also starts to age with us, and that's why our metabolism in part is changing and going down. But what's also interesting is that a lot of the symptoms of your thyroid function decreasing overlap with perimenopause, right? So the memory problems, the weight gain, the irregular menstrual cycles, the fatigue, even joint pain. So there's such an overlap there. I can't even tell, but my personal story was that I was having every symptom on that right side. So hyperthyroidism is your thyroid is functioning too high, and that is much rarer than hypo. I would say 90% of thyroid disease is going to be low thyroid, and then the other 5 to 10% is going to be high thyroid. Rare to see somebody with overactive thyroid, but very common for underactive thyroid. And so I had every symptom, including hair loss, just all the things. And I kept thinking, gosh, my thyroid, I think it's my thyroid. I would go to the doctor and they would tell me, nope, thyroid's fine. I would look at my labs based on my conventional training. I was like, yeah, my labs look fine. I don't understand. And finally, I went to a naturopath, and she looked at my thyroid like a functional medicine doctor would. And that's kind of why I say, if you can't find a functional medicine doc, honestly, a good naturopath will do just as well in most cases. But we're going to look at the thyroid much differently. So the average conventional doc is going to look at your TSH, which is thyroid stimulating hormone. And they're going to look maybe at your T4, which is a prohormone. But in reality, your T3 is the only active thyroid hormone, and the conventional docs don't look at that at all. And so I had what looked like a normal thyroid labs when you looked at the ones that you look at, but when you looked at the actual thyroid function, my labs were in the toilet. So my T3, I should say. And so I was started on a thyroid medication, and it literally changed my life just as much as estrogen did. I actually started taking thyroid medicine before I started taking estrogen. And it was a total game changer. And so the other thing I noticed is that a lot of women in particular are affected by Hashimoto's, which is an autoimmune condition that affects the thyroid. And Black women are more predisposed to have autoimmune conditions. Women in general are 2 to 4 times more likely, depending on the autoimmune disease, to have it than men. So it's, again, any disease I'm finding that affects women more than men tends to not be as either paid attention to, or we're just not getting all the information that we need. But you definitely need to talk to a provider. The typical conversation I hear from my patients is, oh, my doctor told me my thyroid labs were normal. So in the book, I do break down all the labs that are really necessary, because like I said, if you go to your OB-GYN or your just general practitioner, internist, or whomever, they're going to just probably run a TSH and a T4. They're not going to screen you for Hashimoto's. They're not going to look at your free T3. And they're just really not going to be thinking about it. But that is a significant thing that happens, especially in women over 40. And a lot of people have been suffering their whole lives with it. And it hasn't been diagnosed. So it's an important thing to consider. And then the adrenals, are, again, a whole nother animal, but your adrenals really are responsible for just your ability to have a stress or to create cortisol for your stress response. So the classic analogy is the fight or flight, the saber-toothed tiger, but now we don't have the tigers, we got the bosses, we got traffic, we got irritating people, we have whatever, school shootings, we have all types of things that are affecting our stress level, just listening to the news. So that puts us in this constant fight or flight kind of space where we are constantly really running our adrenals. And so over time, our adrenals get tired. And so that is considered in the functional medicine world, integrative medicine world, considered adrenal fatigue. We've just kind of drained our adrenals. But most people have some combination of some issue with a little bit of thyroid dysfunction, which can be fixed oftentimes just by correcting your vitamin D levels. Vitamin D and iron are probably, and magnesium are probably the three most common minerals and vitamins that are deficient and that really significantly affect our thyroid function. But I have seen patients that, especially patients that have a lot of melanin in their skin, or they just don't absorb because vitamin D is converted through the skin. That's why I do believe, and they've shown that patients that died from COVID, like none of them that they had actually looked at their vitamin D levels, none of them had vitamin D levels under a certain point. Vitamin D levels are important for our immunity, to decrease our cancer risk, for all of our hormone function, all the things, blood sugar, like it affects everything. And so, and our ability to fight disease, especially infection. So vitamin D is another one. You want your vitamin D levels, in my opinion, to be at least 50. Ideally in our world, it's 60 to 80, but I see so many people with vitamin D deficiency, and then their doctor tells them to take it, and then they take it, and they're like, okay, and then they stop. But you can't stop taking it. You've got to keep taking it. It's the only vitamin that our body makes. So just think of it that way. It's probably important if it's the only vitamin that our body actually makes.
Dr. Arianna, I know, and we're looking at the time, and I'm listening to you. I'm like, oh my gosh, if we had another half hour, you're probably saying, well, yeah, but we don't. But if we had some more time, I would love for you just for 1 minute just to talk about, because the book also talks a lot about self-care. And, I love the latter part of the book that talks about a healthy, sexy glow. And looking at this part of our lives as a life to, what do you say? I think you call it what the latter 40 years of our life or something like that. But what can you share with women, encouraging them, that also ties in with what you talk about in the book, so they'll know what what to look forward to, but where they can find information around self-care and so forth in the in your book?
Okay, that's a loaded question.
I know.
But it's fine. I wasn't even looking at the time, but it's all good. I have a few more minutes if you're, I mean, it's okay. I'm okay. So if you guys, what time do you want to,
well,
tell me?
we had a schedule till 2:30, and it's 2:28 now. So perhaps, and if people could just hang on with us for another maybe 10 minutes, I don't know. I think that might, what do you say, Cheryl?
Yeah, giving
that would be helpful.
Space to answer this loaded question. Yeah,
it is a loaded.
Right.
So I tried to condense it. I got thumbs up, and if anyone else, give us a thumbs up. But please, Dr. Arianna.
Okay,
Well,
I'm trying to figure out.
Well, you know what? That I'm going to take a step back then, because what I
Okay.
really wanted to talk about, and to be honest, you talk about gut health, and inflammation at the core of about every disease there is, right? Even so, the gut is one of the most, you say, one of the most neglected organs in the body. Could you just give us a description? What is inflammation, and why did you decide to address this topic so thoroughly? I knew it would take a little bit more time, but if you could talk a little bit about it.
Yeah, well, it's because the gut is everything. Like at the end of the day, food is your number one medicine. And my personal experience with doing the food elimination diet, which I talk about in the book,
Yes.
And what that food elimination diet is you're eliminating gluten, dairy, sugar, alcohol, corn, soy, nightshades. There's a whole list. And basically, you can't really understand what's happening with your body if you don't really understand what's happening with your gut. And your gut can affect, I mean, it's everything. So my experience with the food elimination diet was I was having all of these issues, joint pain, headaches, just fatigue. I was just out of sorts. And I went to a naturopath once again, and she put me on this diet, and I was just like, okay, take away this, take away that. I understood all of it, but the one thing she told me not to eat was nightshades. Nightshades are potatoes, tomatoes, peppers, goji berries, stuff like that. And I was like, tomatoes. And at that point, I had a tomato garden. I ate tomatoes every day. I was like, this lady's, what is she talking about? No tomatoes. So I was like, fine, I'm just going to do it. So I took out everything, gluten, dairy, sugar, alcohol. And I had never felt better in my life. Never had more energy, never had more mental clarity, never. And I took it all out and I was like, okay, I'll take tomatoes. So you put each food back one by one so you can see your response to that food, because you don't realize it. You may very well have some food sensitivity, and they present in all type of ways. It's not just your stomach hurts. It could be headaches. It could be skin irritations. It can be mood swings. It could be weight gain. And obviously the gut issues, bloating, constipation, abdominal pain, ADHD, like it affects so much. And so I took everything out and I was like, well, I'm going to put these tomatoes back because I know it's not these tomatoes. And lo and behold, I ate the tomatoes. And when you eat, you don't combine, like you're not going to have mac and cheese because that's gluten and dairy. So you would only eat the dairy or you only eat the gluten. So it takes time and it takes a commitment, but you put it back and then you wait a few days and you look and you see, how did I sleep? How did I feel? How was my mental clarity? All the things. But inflammation at the end of the day is the root cause of disease, and the food that we eat are a big cause of this inflammation, even if it just ultimately is raising our blood sugar. But for me, when I put these tomatoes back, the next day I woke up, I literally felt like a Mack truck had hit me. I couldn't hardly get out of bed. Every joint in my body hurt. I had the worst. I was having a lot of headaches and I couldn't figure out why. And it was the tomatoes. And I was like, are you kidding me? I was so hurt.
I believe it.
So hurt. I was like, oh, not the tomatoes. I mean, I love bruschetta. I love it all.
Me too.
And it just really, it just informed me so much. And so I put every patient on that. I tell them, I know it's hard. I know we're very attached to food, but so much of the food we're attached to is just that it's not our friend. Your food, certain foods are just not your friends. And as we get older, our gut becomes more sensitive because we get what's called leaky gut. We get more gap junctions. So the food that's initially meant to just go through our body, our gut is supposed to be a cylinder where the food and just the nutrients are extracted. But once we get leaky gut, there's like openings. And so then more food can actually go into our bloodstream. And so we're having reactions to that food based on the integrity of our gut. So leaky gut, I would definitely look that up. I didn't go into it in a lot of detail in the book, but it's a thing. It's actually just really being recognized now more in conventional circles, which I'm happy to see, but this has been, we've been talking about it for decades. But basically inflammation is the root cause of disease. And so once you are figuring out foods that are inflammatory. So any animal product food, anything that's processed, sugar, like all of those things are inflammatory. And so you really want to focus on an anti-inflammatory diet. So those are things like avocados and wild caught fish and walnuts and almonds and things that are basically high in omega-3 fatty acids, because what those are going to do is increase your HDL, your good fat, right?
Yes.
And your good fat is what is really cardioprotective. And so your inflammatory foods are going to increase your bad cholesterol. I said your good fat, your good cholesterol, your HDL. But you want to increase that. That's good. And so your food is just a huge part of it. And so if you're going to start anywhere, you want to start with your gut. Look at the food elimination diet. If anybody just, they can send me a request, even through Instagram or whatever, I can send you the link. Full Scripts actually has a wonderful guide. That's the guide that I give to all my patients. I just send them that link. And I just tell them, you can't cheat on it. You're not cheating anybody, but you literally take all that food out. We are really addicted to food, and you have no idea how it's just trying to have these conversations with patients. People they almost get indignant about taking away their food. Like, what do you mean? I can't eat what? Like, and it's like, yeah, but just trust me, it's one of the best things you could ever do. And you'll feel so much better. Now, trust me, I say all this, but don't get it wrong. I just was at Eddie V's last night eating me some crab meat fried rice and some calamari, and I do all the things. So I'm not by any means, I do it all. But I'm at least aware. Yes. And I know I don't even feel my best right now because I know I'm eating things that really don't serve me, but at least I know. Yeah. And you can't know until you just take it out, and so you can just see how good you can feel. Yes. And that doesn't mean it's going to be easy going forward, because I did this 20 years ago and I still have never been able to do it completely again. Not maybe once or twice, but it's hard. It's not easy. It's a commitment.
And, it's interesting. Thank you for walking through inflammation and leaky gut and all of these terms that we've heard a lot about. And of course, people can look them up, but you focus a lot on food, inflammation, and the gut, what the gut's got to do with it. And that's in chapter 6 for folks who have the book or who plan to purchase it. And I was just amazed at how thorough, and in depth you went, because I understand the importance. I had an issue with a gastric issue recently. And when they told me, said, do you drink coffee? And I knew this, do you drink coffee or caffeine? I was like, yeah, well, guess what? There are things you need to eliminate. And you mentioned tomatoes. You need to, eliminate that. I garden as well. And, I'm looking outside right now and I have my little red cups of, of tomatoes.
Well, I'm not saying that you have to, because they may be fine for you. For some people, they're great. And
no, they're not good for me.
Oh, okay. Well, if they're not good, they're not good. Just know that. But the caffeine in particular, that's the one thing I tell people is it's generally not the caffeine. It's what you're putting in the caffeine. It's what you put in your Starbucks coffee. Okay. It's not the coffee as much. So when I get pushed back and they're like, oh, what? You want me to not drink my coffee? I know. I'm like, okay, you can have your coffee, but you're going to have to put unsweetened almond milk in it or oat milk or whatever. But it can't be dairy and it can't be sugar. Right. And you're just going to have to get a new taste bud there for a minute if you need the caffeine, or just, I just take some Excedrin and deal with, I have to get it to get away from the headaches that I was going to get. That's what I did. I just said, well, I'll just take Excedrin for a week until this caffeine withdrawal goes away.
Mm-hmm. Well, so then this other question that I tried to, cram into something else, you say in the book, sometimes changing the health of your body starts with changing the health of your mind. Throughout self-care is a huge theme, But the latter part of the book does go deep into the, which I love, healthy, sexy glow. That's in chapter 7, and the rebirth and reinventions, jewels for the journey. That's in chapter 8. In the latter chapter, you talked about self-mastery, and you talked about martyrdom and radical self-care. The martyrdom really stood out as something, I think, as women, that we find ourselves, being the superheroes, but often not in our own, lives. Do you mind just speaking just briefly about that?
Yeah. So women in general, and I would say especially, African American women, but all women, honestly, that I see, we take care of everybody. We take care of the kids, we take care of the partner, we're taking care of people at work, we're doing all the things. And, for me, just sat back and I'm like, well, who's taking care of me? Like, literally. And even though, I have a great partner, he's really supportive. And I mean, in his way, he's taking care of me. But at the end of the day, you got to take care of you, because if you want to be able to show up and pour into the cup, right? We cannot pour from an empty cup. It's just, there's nothing there. If it's half empty, it's half empty. It just is what it is.
That's
So
right.
you got to figure out what that looks like. And so I feel like so many women, they just almost feel like it's a badge of honor to be like, oh, yeah, I just, they're just doing the most. And it's like, but, how is that really serving you? And how are you really feeling? And so, when you're not really paying attention to that, then, then they get resentful. But it's like, but you chose to do this. And although there was probably an expectation on some level, you get to change that narrative. And that's what the beauty of, I think, this phase is that and literally, as our estrogen levels decline, our brain chemistry changes, and we go from being the nurturers, just to the women that we were designed to be. We are designed to be nurturers, but once we're done nurturing, we're done nurturing. Now it's time to live. It's time to do the things. It's time to do the thing. And so, and it's okay. The kids are gone, the partner may or may not be there. But it's the time to really start thinking like, what am I here to do? And what's for me? And you can either stay on that path of making sure you're taking care of everybody else's business, or you can really start to look inward and figure out what it is that brings you joy, figure out what you feel like your purpose is. So many times we're in careers that we don't like, that we just kind of stuck out just because it just made sense, or it wasn't practical. But all bets are off now. I have a friend who just literally took the whole month of May, and she still has one kid in her house. I was like, I don't know if I wouldn't have been that bold, but I don't have any kids in my house now. But she literally took the whole month and she traveled. I know that's not accessible to everybody, but she went to Paris and Milan, and she just did it. She left her husband, she left her kid, and she just decided to do her.
It was her time. It was her time.
It's her time. And so I call her, that's actually my friend Leslie, who wrote the foreword in the book. So she is, but I told her, you're my hero. And I'm not, and when I first saw her doing all that and posting all her trip pictures, I had a little, I'm not gonna lie, I had a little hate. A little hate.
Exactly.
So I was like, how'd she do that?
You're doing that.
You know what? I could do that. Like, I have to figure out my life in a different way. I created, certain expectations, but it's like, no. And maybe it's not going to Europe. Maybe it's just taking a month, whatever that is, that thing that is going to feed your soul. Figure out what that is and figure out how you're going to do it. And don't make any excuses, because that's all they are at this point.
I love it. I absolutely love it. And I know I have one thing that I want to read and then offer the opportunity for you to have closing remarks. But in your conclusion, you include actually two powerful statements. Okay, the first, it reads, midlife is when the universe gently places her hands upon your shoulders, pulls you close and whispers in your ear, I'm not screwing around. All of this pretending and performing, these coping mechanisms that you've developed to protect yourself from feeling inadequate and getting hurt, it has to go. Your armor is preventing you from growing into your gifts. I understand that you needed these protections when you were small. I understand that you believe your armor could help you secure all of the things you needed to feel worthy and lovable. But you're still searching, and you're more lost than ever. Time is growing short. There are unexplored adventures ahead of you. You can't live the rest of your life worried about what other people think. You were born worthy and love. You were born worthy of love and belonging. Courage and daring are coursing through your veins. You were made to live and love with your whole heart. It's time to show up and be seen. And that's a Brene Brown quote, right?
Oh, okay, I was like, did I write that? That sounds good.
But
I
listen,
don't think I wrote that.
but I'm going to read, I'm going to read what you wrote, and I'm going to ask you, because there's something just beautiful in both these statements. You write, when will you be ready?
Yes.
When will you be ready to see your own greatness, to move your own mountain? There are no more excuses, only the possibility to live your best life. Only the knowing of spirit that speaks to you, spirit that knows, spirit that guides. Pull up your passion, confront your fear, decide that you are ready and move. That's what you wrote. So
I did write that one. Yes.
you did write that, and
Yeah.
the inspiration behind, and you can say final words, but there's a lot of just energy in both those statements.
Yeah, I wrote that actually, probably, I didn't realize it at the time when I started going through menopause.
Excuse me. I know that we may have questions. I'm not sure, but if we could please check our mics and to ensure that they are closed. Thank you.
Yeah, I think I was going, that poem, I wrote it years ago, and probably, I don't even remember, at least 16 years ago. And I wrote it as a poem, thinking I was writing it for other people, but it was really for me, and really was a poem to myself about just feeling like, when are you going to be ready? And, you know, that was, again, almost 2 decades ago that I wrote that. And I'm still like, when are you going to be ready, girl? Like, when are you going to do this thing? Like, so I'm still not there. Even myself, I'm still every year, it's just like, I'm still evolving. I would say this year, I probably I feel like a nice little evolution surge happening here. Like, I'm looking at my work. I'm looking at, I think I need to change. Like, some things aren't serving me anymore. I don't want to do this. And I'm like, what is my best life look like? And I think that's the question, is that we don't really ask ourselves, is what does my best life look like? What do I want to do? And we get so caught up in just the day-to-day and just the monotony of going to work and doing the things. And then, but this is the time. Like, if it's not now, when is it going to be? And so I felt that way, like I said, when in my 30s, early 40s, I'm 57 now. Now I'm really like, okay, I need to pull that out. And I have actually started looking at it more like, okay, you wrote this, when are you going to do it? So that's just my invitation to every person, and women in particular, to just figure out what that looks like for them, and to go and to do it. It's and it doesn't mean it's easy. It's not a straight path. It's crooked, and it's, you're confused, and but it's all good. It's all it's all about the journey anyway, right? There is no destination. Right. But how do you want to journey now? How do you want to travel? Do you want to travel with all this baggage and stuff that's not serving you? Or do you really just want to figure out what your best life looks like? And so I can't say I figured it out. I'm getting closer, but yeah. I don't know if we ever know what that looks like.
I was just going to say that. Yeah.
Yeah, I think it changes. But now I'm like, my best life, now I've seen my friend Leslie travel. My best life is traveling. That's what I need to go
do. That's exactly, and I have plans for that as well. I thank you. I thank you all. I don't know if you all could just I want to read a few comments to say thank you. So many nuggets. Someone else said that they're going to buy or purchase. I think it was Sue who said she's going to purchase a copy of the book for her office.
Okay.
And Cheryl, am I missing anything? Anything that you caught that I did not?
No, I think that's it for the comments. Yeah.
Okay. All right. Well, yeah, we have a lot of stuff. Okay, right. So I would like to, I'm going to share, we're going to share a poll with everyone. And if you can let us know if there are other topics that you would like to see IAWH address. In the meantime, I will continue just to say thank you to Dr. Arianna Sholes Douglas. We have dropped, we include, I have to stop saying drop. We include, put into the chat, how to reach you on Instagram, your website, as well as where to purchase the book. We've included that link as well. And if you all have any other questions, I'm sure there's opportunity to send comments in on her website. I think there's, I think for more information, I think about the work that you do is on your website, and that's drarianna.com. And I should have that in front of me. But Cheryl, any other words that you have to share?
Just very quickly, thank you so much. This has been just so enlightening. I wish we had even more time to pick your brain on the things that that women experience and how learning from you how to navigate through all of those difficulties. But thank you so much for giving us this afternoon.
Yeah, my pleasure. It's always a pleasure. I usually ask people to get off their cameras so I could see people's faces. It's a little interesting because I didn't know if I think I saw one person, but I get it. Thank you. I'm just
yay.
I like to see like who's here. I get more energy. I like to know like who I'm talking to. So
yeah, and if anyone else, please come off camera. We have a few minutes, and if you have the book, you can hold it up. And if not, give us a wave and stay on camera for a few minutes. Just because there is a lot of energy in seeing faces and so forth, which is why.
Yeah, it is. It is.
Yeah.
But I understand. I feel like when I do Zoom, usually when I start, I'm like, okay, y'all need to get off the camera. I don't care if you got your rollers in or whatever. We're good here. Do what you got to do.
Exactly. And sometimes, yeah, I see everyone. Thank you all. Thank you. I see Sheila. I see, yeah. And I feel like the romper room woman. Yeah. Do you remember romper room? But
yes.
And you all please drop into the chat if there's some nuggets that you take away with you, or how you plan on passing the information on. We included like 4 calls to action to include, do your own research, speak to your clinician, please bring up topics to your clinician, even questions that you have. Make sure you do that and let somebody else know that you have been engaged, in this search, and provide them with resources that you've gathered today, because that's what it's all about. We're on our phones all the time, our laptops, and we can share this bit of information as well. So you may see that we put that into the chat as well. Just a few calls to action that you all could take. And with that, I'd like to say thank you all very much. Thank you for your time on this beautiful Sunday. No matter where you are, we are here, we are alive. And I hope the best for you. And I see there are comments in the chat, and I'll look at that. I don't want to miss anything. Sorry. Thank you so much. Some useful information. God bless. Thank you. I learned a lot. Thanks. Took notes. So that's great. Thank you. That was Marlene. And then another thank you. Thank you so much to Dr. Sholes Douglas. Great discussion today. That's from Nadine Sands. And of course, with the comment about great nuggets, and I agree to that. So thank you all. Have a great day, and thank you for joining us.
Thank you for having me. I appreciate the time.
Yo, thank you. You're welcome. Anytime.
Thank you. Thank you all.
Thank you. Thank you.
Bye-bye.
Bye.
Well, thank you again.
We thank you for your time and for the added time as well that you gave to us, and just it's so much that
I know it's a lot.
I know it is a lot, but you know what we know is that all it takes is just, well, as someone mentioned, a nugget, right, of information. That one bit leads to another. And I truly believe, and I know I've said this many times, this is a handbook, and it's a gift that you can give to others as well. It's like, hey, we may not know a lot. And I mean, all of us, we don't know everything there is to know about menopause, or how for us to, to work toward having a healthier, health and wellness. But guides like this, and yes, handbooks, guide like this, it takes us, along that path, and it strengthens us, and, nourishes us in